first of all, my colleague, Dr. Sikander Ailawadhi. Sikander is a good friend and colleague from Jacksonville, in Florida, and he's going to tell us about the management of newly diagnosed myeloma. Thank you very much.
Thanks a lot, Rafael, and thanks everybody for inviting me over. This is not bad weather. This is great. So I'm really looking forward to this. So I started at Mayo about 5.5 years ago, and when I was starting, one of the meetings, which we have about 40 of us who focus on myeloma, it was mentioned to me, or I mentioned to someone, hey, I see about 5 to 7 new MGUSs every week. Don't I get to see more myeloma? They said, no, well, the #1 risk factor of getting MGUS in the world is coming to Mayo Clinic. You enter through any door, someone throws an SPEP, it comes back positive, and the patient ends up with one of us. But it's been a very interesting and a very lovely journey. So I'll focus more on some of the studies, and some of the studies are more for information for you guys to keep on your radar. I'm focused on, this talk is focused on newly diagnosed myeloma, including stem cell transplants. So what I've done is try to preface the new data with some current standards, and then talk about more recently upcoming new data that is shaping up how we treat myeloma. So when we see the patients, new patients, there are lots of factors that go into the decision-making process of who gets transplant, who doesn't get transplant, who gets a triplet, who gets a doublet, what agent to use, et cetera. So this is traditionally what we've said, and you've probably seen in many, many talks, but we use it on a day-to-day basis. Each one of us who treats myeloma, we do go through literally all of these when we see a patient to try and figure out what to do. So patient factors, the myeloma frailty score is helpful. I can tell you that most of us probably don't sit around on a calculator to calculate that, but that factor does go into our decision-making process, how frail or fit the patient is. Disease factors, whether it's the risk stratification, high or standard risk, we finally made it simpler because there's no intermediate risk anymore, so it's either high or standard, makes life a little bit simpler. Any end organ damage, especially kidney dysfunction, any myeloma crises that the patient is coming in with. They have a bad plasmacytoma causing paraparesis, or plasmacytoma in the clivus, bad kidney dysfunction, so we need to act yesterday, sort of a thing. So that helps decide what regimen to choose. And then support system, insurance coverage, distance from treating center. Very, very important. Does the patient have insurance for specialty medication? Can they travel to the center frequently for infusions or IV or injectables or not? So we do take all of this under consideration. So I'll put some of the transplant, quote-unquote, ineligible patient currently standard use data within the next 2, 3, 4 slides. But I should mention that the term ineligible is a little bit of a fallacy, because what may be ineligible for me may be eligible